Hey everyone, and welcome back to Clinical Physio with me, Phil Richards. In today's video, we're going to be going through active range of movement testing for the wrist joint. We're going to be going through the key movements involved and the muscles involved in those movements. If you're not sure why we test active range of movement, look at our video titled Why Test Active Range of Movement for all the answers and explanations on it. Remember, we always want to be testing left and right, so the ipsilateral and contralateral. So to not slow your videos down, we're only going to be testing one side. So when we're thinking about active range of movement testing, we need to consider three things: P, Q, and R, which stands for pain, quality, and range. If you're not familiar with P, Q, and R, here's a short recap. Otherwise, head straight into the next video.
So as we have said, when testing active range of movement of any joint, we need to consider P, Q and R. P for pain, Q for quality of movement, and R for range of movement. In terms of pain, if pain is present, we know that there is a dysfunction within this movement, which may be causing our patient's problem, and will likely direct further testing to this area to try and isolate the source of the pain. If pain is not listed as part of the examination, the therapist can move on to the next stage. For example, if there is no pain on active lumbar spine movements during a hip examination, the lumbar spine can be ruled out of the initial investigation. In terms of quality, good quality indicates that the brain and local tissue are both happy and able to perform the movement. So what does that look like? It means that the patient will look very willing to move and have sufficient power in movement with good control and coordination. If these are lacking during the movement, quality can be questioned, and thus likely direct further testing to establish why the movement is of poor quality. For example, weakness, which could be due to a myotomal weakness from a spinal pathology, or a deconditioned muscle from the local area. In terms of range of movement, too much or too little range can indicate a dysfunction within the movement, and could also help us identify the patient's condition. As a therapist, it is always important to use the range values within your movement test as objective markers and for you to compare the specific range values in each treatment session. It is important to know the range at which your patient's pain starts and the range at which the movement ends, as often these two values will be very different. For example, if we only measured the movement at which pain starts, we do not actually know how much range the patient can achieve. Essentially, a lack of range indicates that there is a stiffness or a weakness which is preventing full movement.
So let's take a look at active range of motion of the wrist into flexion. Now you may have seen when we were clearing the wrist, when we were talking about active range of motion of the elbow, that we had the arm in this position and we performed our clearing from here. We can still do that for active range of motion of the wrist into flexion coming this way. I'm just going to show you how I like to do this in clinic so that you don't have to think about different positions. You can just be in one position and transition very easily. Just makes it easier to learn. So we're going to start by popping the forearm flat on the table, ideally at kind of 90 degrees. So as the therapist, we're going to be opposite or beside the patient, and the patient's going to be sat with their forearm arm rested with the elbow at 90 degrees. So all we do from here is just demonstrate the movement we would like the patient to do. So we say, Polly, can you just bring your wrist down like so? And then they will then perform this active movement. From there, we're going to add our overpressure. So Paul, if you can come back into here. And what we're going to do is support anywhere around the forearm. And then we're going to provide the gentle overpressure on the dorsum of the hand. We're not going to be cranking from the fingers. And we want to be careful if people have pain in and around the area that we're not just pushing on that part. But anywhere from around here to here, you can provide that overpressure and get that end feel. From here, you can also use your goniometer and measure round. So if you have a hand therapist goniometer, you can measure around this aspect. And if you've got a regular goniometer, then you'll be measuring on the side here. Thinking about the muscles that are involved, we've got quite a bunch here. So examples are flexor carpi ulnaris, flexor carpi radialis, flexor digitorum superficialis, and the digitorum profundus. Palmaris longus may be present in some of the population, and flexor pollicis longus will also contribute to active wrist flexion. So thinking about our P, Q, and R, so let's start with P for pain. Well, we know it's an active movement, so it could be the muscles involved. So any of the ones we've mentioned, it could be them as a contractile lesion. Other common things would be compression of the carpal tunnel in here, which is getting squeezed, similar to our sort of phalans, reverse phalans type tests. And this could also be associated with the paresthesia in the hand. We've also got to think that we're causing compression in and around the radius and the ulnar and the wrist itself, so it could be an articular joint problem that causes the pain. That is more likely to be a local pain here rather than an active muscle lesion. You might expect it to be radiating more down the muscle bellies. Also, what could be happening if we're getting pain on this is we're passively lengthening the extensor component, so that could be another thing. Moving on to Q for quality, it's not common to see particular quality issues with this. The main thing you're going to see is if people have a wrist fracture or chronic wrist stiffness, is as you ask them to do this movement, what's going to happen is they're going to get to about here, then the fingers are just going to curl down, and they'll believe they've gone quite far, but it's actually just finger motion. Nothing's happened at the wrist joint. And then just thinking about the range, we're expecting around 75. There is going to be a bit of variability. So for instance, on pole, we would see that's kind of a right angle, so we're thinking more 90. But anywhere between this sort of 75, 90 would be deemed normal. So now we're going to look at active range of motion of the wrist into extension. So as a therapist, we're going to sit beside or opposite the patient. Our patient is going to be sat with their arm rested either on their lap or a table, preferably with the elbow around 90 degrees, just so we can eliminate contributions from the shoulder as best we can. All we do from there is we ask our patient to do wrist extension. So we show them, we say, can you do this motion for me, please? And thus the movement is done. From here, we need to provide our overpressure. And we need to provide it by coming in close and pressing around the carpals. So if you want to, you can come in and do kind of a handshake position, support the forearm and provide it there. As I'm pushing, I'm angling kind of this way. I'm not pulling back this way because I don't want to pull at the fingers because it's going to stretch out this whole component here. That might be helpful for later for trying to work out if it's more of a tendon issue, etc. But we're thinking about testing the wrist. And if I stress back this way, I'm adding extra stuff in. So think about coming snug and close and providing the overpressure there. So when we're thinking about active movements into extension, we need to consider what muscles are being used. So we've got quite a few here. So examples would be extensor carpi ulnaris, extensor carpi radialis longus and brevis. We've got extensor digitorum. We've got the contributions from the thumb. So we've got extensor pollicis brevis and longus. Even the little finger on the back is going to come higher up, so extensor digiti minimi, and the index finger, extensor indices, is going to have a component role with it as well. So there's quite a lot going on there. So now let's think about our P, Q, and R. So P for pain. Well, we know it's an active thing going on, which requires muscles to use. So if there's pain being created by the movement, it could be one of the muscles we just talked about. The other thing it could be is compression in at the wrist, so we know it could be an articular problem here. If it is an articular problem, it's likely the pain will manifest here, although it's interesting to note that a lot of people with articular problems sometimes complain about some pain radiating up, which can mimic tendon problems. So if you do have someone that has pain and it is at here but is also radiating a bit up the bone, that's still probably likely to be an articular problem, but the rest of your examination will kind of confirm that anyway. So let's go through it again. So we've got active stuff, so it could be the active muscles causing the problem. We have wrist compression, so it could be an articular problem. We also have passive lengthening of all the flexor muscles, so it could be something to do with that or the fascia that's getting irritated, so it could be that too. Just a little bit of bonus things to think about is the TFCC, which is the triangular fibrocartilage complex. So this would be a type of articular problem, and essentially what it is a band over the top of the ulnar, which is commonly disrupted with trauma when people sort of land out with a foosh or hit down, foosh being fallen on outstretched hand. So this could be a problem specific to articular things. That's worth looking up because that will come up now and then, as well as your standard fractures. So let's move on to Q, so quality. There's not normally any issues with this in particular. You don't see too much spasm or juddering, except with fractures. Tends to be quite awkward to want to move. The muscles don't want to engage. But you're also going to see with fractures and chronic stiffness, this inability for the wrist to come back, and the fingers will want to open, and nothing will really be happening at the wrist. So we'll say, hey Polly, can you pull your wrist back like this? And all that will happen is the fingers will fan back. So when you're measuring with your goniometer, which we'll come on to a second, the range, well, let's just go through it now. So we're looking for about 70 degrees. So Polly can get to 90. So anywhere between 70 and 90 is normal. When we're using the goniometer, just make sure you're measuring here and not focusing on the fingers here. You can really kind of mislead yourself in thinking the patient's making progress when you're looking and focusing on eyeballing this angle and not this angle. So remember, we're measuring here. As we said, we want between 70 and 90. Your wrist fractures are going to end up here. If they've had something like an ORIF, then it is normal for them to not be able to reach their full potential, but you're still looking for a decent level of function. So you're still looking for something around the 60-70 mark. So next we're going to look at active range of motion of the wrist into radial deviation. So let's recap. We've gone to flexion and extension. So all we're going to do from here is just flip over into this pronator position, and now we can do our radial and ulnar deviation. And we're looking at radial deviation, so let's get straight to it. So as a therapist, we're going to be sat beside or opposite the patient. Our patient is going to be sat with the elbow in around 90 degrees, forearm rested on the table. So from here, we're going to just demonstrate the movement, because it's a lot easier to say, can you do this for me, please? Just bringing your thumb in towards your middle. And then the movement is performed. So from here, we need to do our overpressure. So as they come in, we're going to scoop up and support the forearm however you wish, as long as you're not too pinchy. I'm going to grab in from the radial aspect, and then we're just going to add in that bit of pressure. What we're not looking to do is come too high and pull in here. You're going to get, as you can see, the MCPs coming into flexion. It's going to be not very controlled, and we don't really know what we're kind of compressing chiefly here. We want to get as snug as we can to the joint and add the compression in there. Also, because we're trying to test more of the radial aspect with this, try and imagine that you're thinking about that radial bone and the carpals, and you're trying to squash it together to see what kind of quality you've got, rather than kind of doing a compression down. So you really just imagine what's happening, and you'll get a better appreciation for the end feel as well. So it's an active movement coming in this way, so we want to think about the muscles involved. So we have the flexor carpi radialis, we've got extensor carpi radialis longus and brevis, and we do have the abductor pollicis longus, not the brevis but the longus, and we have the extensor pollicis longus and brevis contributing to this movement also. So let's go through our P, Q and R, so pain, quality and range. With regards to P, we know the active muscles are contracting, so if there's pain it could be from one of those muscles we've mentioned. We also know that as we're coming in this way, we are compressing the radius in the carpal region, so we could have an articular issue going on here. And also, if you have, just to mention, sort of de Quervain's tenosynovitis, that tends to also, because of the proximity of it, get quite irritated on this movement, which could be a little bit of a red herring when you do that, so just be aware of that. But the rest of your exam will show up what it is, so don't worry too much about it. They're really the main things. So let's talk about Q for quality. Well, this one, we don't really need to kind of build too much detail on it. It either tends to work or it doesn't, and the ones where it doesn't tend to work is when it's associated with fractures or stiffness. You're just going to see barely any movement. In fact, Pole, I would say here, has less than normal movement. But other than that, you're not going to see much else. It'll either get there or it won't. And then let's move straight on to R. So we're looking around 20 degrees, which we don't really have here with Pole. So we could look into maybe there's excessive compression or muscle tension related if we wanted to go that far into it. But normally we'd expect, if I show on my hands, that we'd be able to come in more at that kind of angle, which would be your 20 degrees. So now we're going to look at active range of motion of the wrist into ulnar deviation. So as a therapist, we're going to sit beside our patient or opposite our patient. Our patient will be seated at the table with the elbow in around 90 degrees, so we can try and exclude contributions from the shoulder. All we do from here is we pop our hand on the table also, and we show the patient the movement we'd like them to do. So I say, Polly, can you do this motion for me here? So bring in the pinky out to the side with the rest of the hand. And then the movement is performed like so. From here we need to provide our overpressure. So what we're going to do is we're going to swoop in as close and as snug as we can get to the carpals, support the forearm, no pinchy hands, and we're going to provide the overpressure from there. When you're doing it, please don't grip too high. What's going to happen is you're going to end up compressing MCPs, different joints around here. We're trying to isolate the wrist. So effectively what I'm doing is, if you can't see from my hand blocking there, is I'm just getting snug into the carpal bones and pulling across that way. You're trying to imagine you're compressing this aspect, so the ulnar carpal aspect. Okay, so when we're doing this movement, there are obviously muscles involved, so we need to talk about them. So the muscles that are involved in this are flexor carpi ulnaris and extensor carpi ulnaris. And now we need to think about our P, Q and R because we're doing active movements. So P, Q and R for pain, quality, range. So if we think about P for pain, so if we're getting pain on this movement, it could be the muscles, because we've just talked about those two muscles that are providing the movement. Also, because, as we mentioned before, we're compressing in at the ulnar carpal joint, we could have pain at this articular region here. So that could be related to a distal ulnar fracture or a carpal fracture in and around here, or it could be something to do with the TFCC, which we mentioned before, which is the triangular fibrous cartilaginous complex. Basically, it's just a little cartilaginous disc that sits in here that helps with articulations, but that can be often irritated with trauma. So let's think about Q for quality. The main reason you're going to see a loss of quality is going to be due to chronic wrist stiffness or bony deformity associated with fractures or just fractures themselves. And what you're going to see is just not very much movement at all. You might see a token gesture with the fingers desperately trying to come round. And the other common thing to do is to swoop with the elbow as the patient is desperately trying to do more movement for you. So just try and be quite disciplined with keeping the elbow in position and trying to get a pure movement. With regards to range, we're looking at around 35 degrees, and this looks pretty normal. If you've got a common wrist fracture, expect, especially early days, for it to be around that. But we are looking at a reasonable motion here. So now we're going to go through active range of motion of the wrist into supination. And you may have heard that this is like holding a bowl of soup if you are struggling to remember your pronation and supination movements. So as a therapist, would normally be sat in front of the patient, but I'm sure you can appreciate if I'm sat in front, you won't see anything. So I'm going to be to the side for this one. And our patient's going to be sat with the arm rested on the table, mostly because we'll have gone through our other wrist movements from there. So all we need to do is keep 90 degrees of elbow flexion here. For this one, we're going to get the patient to just slightly lift the arm off the table, and then we're going to ask them to just turn their hand up as far as they can so the palm is facing towards the ceiling, and thus active supination is performed. From here, we're going to add our overpressure. So this will purely depend where the patient is sore and getting pain. So to start with, you might want to come in and secure around the carpals and the wrist, so that you know you're providing your overpressure from the wrist like so, and just add that overpressure. You may find that they don't like you doing that because they have pain here, so even to touch the skin if it's very sensitive, like something called allodynia, you might find that you want to go a bit further up the forearm to provide the overpressure so you can still get extra compression here. So you can come a bit further up and just provide your pressure from here, however you want to do it. Preferably as close to the wrist as possible, not too far up the forearm, or you're going to end up causing more articulation at the elbow than the wrist, and we're thinking about the wrist. And so let's talk about the muscles involved in supination. So we're thinking about the biceps brachii being involved, the brachioradialis, and the supinator. And because we're talking about active range of motion things, we need to talk about our P, Q, and R, so pain, quality, and range. So if we are getting pain on active supination, it could be because it's active and the muscles are being involved, one of the muscles we've spoken about. That could be an overuse thing or a trauma type thing, anything like that. The other thing that could be happening is a problem with the articulation between the radius and the ulnar, because they are articulating as we're moving over. So we could have a problem in here, so commonly related to wrist fractures, and also the interosseous membrane up here between the radius and ulnar, that can be damaged with gross trauma, so you could have pain coming more up here. That's another thing to look out for. If we're thinking about Q for quality, it tends to be with wrist fractures that they lose a lot of this movement. So you're going to see a lot of shoulder adduction or weird sort of shoulder movements to try and make the movement happen. Just try and look out for that and just be focused on what's happening here and here rather than getting misled by what's happening further up into the shoulder. Just as a note, so you know for your expectations, if you see some bony deformity from like a distal radius fracture, or just the fact they've had a fracture in the wrist, it is common, especially in the older population, despite as much therapy as you will do, they may lose some component of supination. So not as common as pronation, but still evident. So you need to get in there and mobilize this as quickly as possible as you're allowed to. It's not something you can get later on. If you've let it kind of stiffen up for 6 months, this is going to be rigid and hard to sort out. With regards to the range, we're thinking about 85 degrees. So basically 85, 90, as if the two bones can just sit flat on the table. So if you're thinking about that being 0, then taking it over to that sort of right angle would be around your 85, 90. So now we're going to look at active range of motion of the wrist into pronation. So as the therapist, we would normally be stood in front of the patient. However, you're not going to be able to see anything if we do that. So I'm going to be to the side. Our patient is going to be sat comfortably at the table with the arm rested with the elbow in a 90-degree position. So we can try and exclude the shoulder out of the equation. All we do from here is we ask the patient to just lightly lift their arm up so it's not on the plinth of the table, and we ask them to turn their palm over so the palm is facing down. So could you do that for me, please, Polly? And thus a pronation movement has been performed. From here we need to add our overpressure. So what we're going to do is we're going to come and provide the pressure here and support the forearm. Theoretically, but what you're going to find a lot is there's going to be potentially a lot of irritation here, and you're not going to be able to get in and support and provide the overpressure, which would be ideal here. So we can go a little bit further proximal and provide it further up. Try not to be too pinchy. You're thinking of your lumbrical grip here, and just try and be quite soft but assertive with it. So when we're thinking about this active movement that's occurring, we need to think about the muscles. So we have pronator teres, we have pronator quadratus, and we also have brachioradialis. Now, if you've just watched the previous video, you'll have seen that brachioradialis was in that one. So you might be thinking, how could it possibly do pronation and supination? Well, the cool thing about this muscle is because it comes and attaches here, depending on which way it gets, it will get lengthened that way, so it can pull it back that way, but it will also get stretched this way and can pull it back that way. So hopefully that takes a confusing aspect out for you. And because we're talking about active range of motion, we need to be thinking about our P, Q, and R, so pain, quality, and range. So if we think about active pronation, we know that the muscles are involved. So the pronator teres, the pronator quadratus, the brachioradialis, they could all be a source of the patient's pain. The other thing that can be going on is the articulation between the radius and the ulnar, so pain in and around here. There could be some instability in the interosseous membrane, so we could have pain a bit further up here. We could also have instability at the radiocarpal or the ulnar carpal joint. So again, more articular things really could be causing a source of our patient's pain here. Just a little example of something that will be seemingly harmless is a typical worker that does a lot of heavy lifting and work, and they become very neurally tight. They can get excess compression, and you'll probably see in the range that we'll talk about in a second that it's quite restricted and tight. That can be causing problems there. And let's move on to Q, so Q for quality. And the main thing you're going to see is with fractures is an inability to get anywhere really. It's going to have all sorts of weird quality cheats with trying to get the hand, the fingers to curl round and the elbow to kind of adduct and roll, even sort of elevating the scapula, anything to try and imitate the movement. So as best you can, just try and isolate the movement for the patient and just pay attention to what's happening here and try not to be confused by the other things that are going on around there. If your patient really can't do the movement, don't worry about getting too frustrated with them. Just make sure you're focused on looking at the bigger picture here. So now let's talk about the range. So we're thinking around the 70-degree mark. Now if you're thinking, well, hang on, why is the supination one more than the pronation one? Remember that with pronation, the radius bone has to actually cross over the ulnar. So it's like physically not possible for it to like get down as easily as if it's rolling this way. So this way the two bones are sat parallel. So you can always sort of think of that as to why that the pronation range is a little bit less. So with expecting around 70 degrees-ish. A little bit more into 80 is absolutely fine. That's not an issue either. With our typical wrist fractures, pronation, especially distal radial fractures, you'll probably see some bony deformity here in your observation, and they tend to be quite poor. It's something you want to work on as quickly as possible as you're able to, but don't be surprised, and it can be a good expectation for your patient that they may not be able to do it. I will just show you off the cuff now. I don't know if you can see it, but I've had a distal radius fracture and I can't pronate anywhere near as well on that side. So let's summarize this video of active range of movement of the wrist joint. Go through the active movements of wrist flexion, extension, radial deviation, ulnar deviation, supination and pronation. Don't forget to add overpressure to each movement. Make a note of P, Q and R for pain, quality and range for each of these movements. So now you've measured the patient's active range of movement, we would now compare it to the patient's passive range of movement. And by comparing the two, we can see if an active contractile structure is responsible for causing our patient's condition. If this isn't quite making sense, please check out our videos titled Why Test Active Range of Motion and Why Test Passive Range of Motion, so you can quickly get your head around that and head straight to our next video. Thanks guys, we'll see you again soon on Clinical Physio.